Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Michael Khazzam from UT Southwestern, Dallas, Texas. After completing his residency at the University of Missouri School of Medicine, Dr. Khazzam went on to do fellowships at the Hospital for Special Surgery and also the Medical College of Wisconsin, followed by another fellowship at the Vanderbilt University Medical Center. During his fellowship at aTSA, he was awarded the Louis Clark Wagner Award for Outstanding Resident Paper. Dr. Khazzam joined the UT Southwestern in 2011 as an assistant professor and now currently serves as the associate professor and chief of shoulder surgery at the UT Southwestern. Dr. Khazzam is board certified and very active in clinical and basic science research with a primary interest in outcome-based research and evidence-based medicine. He also serves as the consultant reviewer for several orthopedic journals, including Journal of Shoulder and Elbow Surgery, Arthroscopy Journal, and Journal of Bone and Joint Surgery. So today, it's my great honor to introduce you to Dr. Michael Khazzam from UT Southwestern, Dallas, Texas. Over to you, Michael.
Thank you for having me and inviting me to give this talk. So today we're going to talk about preoperative glenoid considerations for shoulder arthroplasty. The goals is to understand glenohumeral joint morphology and its corresponding pathology, and it's critical to understand these for outcomes and survivorship of total shoulder arthroplasty. We're going to provide a summary of the current methods for assessing the glenoid and preoperative planning strategies for total shoulder arthroplasty. So obviously, to start, the most important part of this is the glenoid, and that's what we're going to focus on today because it affects how you make your decisions. The glenoid is pear-shaped, it has width and height, and that's important for assessing inclination and version, as well as the depth and integrity of the glenoid vault, especially in some of the more significant wear patterns, as well as the revision setting. We assess this with radiographic imaging, with plain radiographs, CT scan, as well as MRI, and each has its value in assessing different parts of the shoulder and help in decision-making treatment algorithms. Evaluation of radiographs is important in different planes because you do not get the same view in one plane, and you see this very different assessment even in this picture. So it's important to get at least 90 degrees to each other. An AP and an axillary is critical. Here's some examples of standard radiographs. On the top left is an AP. The top right is a true AP, and you can see it really allows assessment of the joint line as well as the humeral, inferior humeral head osteophyte. On the bottom right is a true axillary lateral, or what Dr. Madsen calls the truth view, where you can really assess the integrity of the glenoid. And then the bottom left is an outlet or scapula Y view. And x-rays give a lot of indication as to what the underlying pathology is and what the cause of the issue is that we're going to be treating. Primary osteoarthritis, inflammatory arthritis, rotator cuff tear arthropathy, post-traumatic arthritis, post-dislocation or post-capsulorrhaphy arthritis, as well as avascular necrosis. So primary osteoarthritis is very easy to identify. It has the characteristic joint space narrowing, inferior humeral head osteophyte or goat's beard, subchondral sclerosis, subchondral cysts, and has this classic pattern of this goat's beard here. As opposed to inflammatory arthritis from something such as rheumatoid arthritis, where you get more central wear, joint space narrowing, marginal osteophytes on the glenoid more than the humeral side. The humeral side is oftentimes spared of osteophyte growth, but there is subchondral changes. There's central wear, medialization of the humeral head, and loss of bone quality. And then this is juxtaposed to rotator cuff tear arthropathy, where there's proximal humeral head migration, changes on the greater tuberosity, as well as undersurface of the acromion, narrowing of the acromio-humeral interval, and then acetabularization of the acromial arch, and superior glenoid bone loss. So this is more coronal plane deformity as opposed to osteoarthritis and rheumatoid or inflammatory arthritis, which is typically axial plane deformity. The X-ray radiograph is critical in aiding in assessment of wear pattern, presence of wear anterior posteriorly, humeral head subluxation, dislocation of the glenohumeral joint line medialization, wear pattern, position of the humerus is critical in assessing and determining what is the most appropriate modality for treatment of the arthritis, because these are linked to survivorship and outcomes. CT scan is our best modality to evaluate all of these things: version, inclination, wear pattern, bone quality, assessment, and status of the glenoid vault, as well as you can get a hint of the rotator cuff quality and status of the muscles. It's difficult without an arthrogram to assess the integrity, but you can assess a lot about the muscle quality, and that can determine treatment outcomes. It's important to understand that 2D versus 3D reconstruction gives a better assessment and understanding of the glenoid wear, and some studies have shown that 3D reconstruction did change the plan in some cases once assessed with more advanced modalities. But it gives a better assessment in 3 dimensions as to the version and inclination of the glenoid. Here's an MRI example, which allows us to get excellent assessment of the rotator cuff as well as muscle quality. And it does give you an assessment of the bone, but can be a little bit difficult in more severe wear patterns to assess exactly what type of wear pattern is occurring on the axial plane. But it is superior to assess details of the rotator cuff as opposed to CT scan without arthrogram. So important assessment of the glenoid includes glenoid wear, glenoid version, glenoid inclination, and glenohumeral alignment, meaning where does the humeral head sit in relation to the glenoid? Is it anterior, posterior, or central? Because these all impact outcomes and survivorship of implants. So let's start with glenoid wear. Classic study from 1999 in the Journal of Arthroplasty by Dr. Walch, and this is still commonly used and the most common classification system that we use to assess glenohumeral joint osteoarthritis in the axial plane, and this classification does impact the survivorship of the implants. So it does direct treatment. But it's basically, on X-ray describes the glenoid wear pattern of primary glenohumeral joint arthritis, and as well as a CT scan. Has prognostic value, it's reproducible, and this has been studied in several cohorts looking at the Walch classification preoperatively and how the patients did following anatomic total shoulder arthroplasty. And basically they found that increasing Walch classification, meaning more severe erosion, deformity, posterior humeral head subluxation, had a negative impact on patient-reported outcomes in a setting of anatomic total shoulder arthroplasty. So worsening humeral head subluxation, glenoid erosion, joint line medialization, all associated with less favorable postoperative results following anatomic total shoulder arthroplasty. And this is why the popularity has become so prevalent of using reverse shoulder arthroplasty in these settings. Similarly, the group out of Cleveland Clinic looked at progression of glenoid morphology in glenohumeral joint osteoarthritis using the Walch classification, and found that not only were these shoulders an issue with regards to treatment, but they also progressed. So an A1 progressed 19% of the time, but a B1 progressed 89% of the time. And progressed mean they qualified this as joint line medialization, more severe posterior glenoid wear, and more erosion and more glenoid vault bone loss. The B types had an 8 times higher risk of progressing than the A types, which makes sense because the A types are centered and the B types are posteriorly subluxed, and we'll review that in a minute. So the Walch classification was modified in 2016 to help better describe some of the more difficult wear patterns that aided in clarifying some of these wear patterns and how these progressed and impacted treatment. So here's the original classification: the A types, the B types, and the C, which is hypoplastic or dysplastic glenoids. In the A type, well-centered humeral head without subluxation, symmetric erosion. The A1 had minor erosion. The A2 is more inflammatory or central erosion, as you can see by this description here, where if you draw the glenoid line, the humeral head is usually medial to this. The B types, posterior humeral head subluxation without, you can have posterior humeral head subluxation without erosion, or which then results in asymmetric loading of the glenoid, and then you get posterior glenoid wear. And this original classification from 1999 started with just B1 and B2. The B2 had a characteristic biconcave glenoid with a neoglenoid, or the new posterior inferior joint that was created by the wear, and the paleoglenoid, which is the pre-pathologic glenoid, which is usually undisrupted anterior glenoid vault and intact subchondral bone in this area. And here's just descriptive diagrams of this. In the top, you can see in red the paleoglenoid, which is the intact subchondral bone. And then on the bottom, as you get posterior humeral head subluxation and medialization and joint wear, you get this neoglenoid formation, because the humeral head then articulates with the posterior aspect of the glenoid. The modified Walch classification from 2016 added some additional qualifiers to this. So as the progression of the B2 continues over time, it becomes a B3, which basically indicates progression of the neoglenoid into a monoconcave glenoid again, and the humeral head appears to be re-centered, even though it's significantly posteriorly subluxed. It is just that the erosion has occurred so significantly that it appears re-centered. And so the characteristics of a B3 glenoid is monoconcave with posterior wear, is usually greater than 15 degrees of retroversion, greater than 70 degrees, greater than 70% posterior humeral head subluxation, and the intermediate glenoid typically is greater than 24 degrees, and we'll review that, what that means in a minute, but it means that the entirety of the glenoid has significant retroversion past 15 degrees. There's usually some superior inclination that has occurred because of the medialization, and then the joint line medialization is usually about 1.5 centimeters. And these all have prognostic indications as to outcomes of how to reconstruct the glenoid during either anatomic or reverse total shoulder arthroplasty. And then the C-type glenoid is the hypoplastic or dysplastic glenoid, where it's failure of ossification of the posterior ossification center of the glenoid, and it's usually a hypertrophic labrum. It's a developmental dysplasia. It's usually characterized by greater than 25 degrees of retroversion. Generally, the joint line is preserved, there's minimal osteophyte formation, and there's characteristic absence of posterior glenoid neck. And these radiographs and CT scans are typically very, very characteristic and easy to spot. Ionati's group out of Cleveland Clinic went on to further subclassify the C types as to C1, which is the classic hypoplastic glenoid, and then the C2 when this became degenerative. So the C1 is dysplastic with high premorbid glenoid retroversion, and then the C2 has acquired posterior bone loss on top of this. So you get this posterior humeral head subluxation, dysplasia of the glenoid, and then biconcavity of this hypoplastic glenoid. And they used what they call the glenoid vault model to classify these things and get a better assessment of how to treat these based on joint line medialization, premorbid retroversion, postmorbid retroversion, as well as the classifications. And then there's the D type, which was also in this 2016 paper, which assesses and classifies when the humeral head is subluxed anteriorly and you get anterior glenoid wear. And the Walch index, which is basically how to assess the position of the humeral head in relation to the center line of the glenoid, is typically when 50% is neutral. When it's less than 40%, that means it's subluxed anteriorly. And here's some descriptive assessments and examples of this. So the Walch, again, Walch classification describes glenoid wear patterns in the axial plane and is used for primary glenohumeral joint osteoarthritis, whereas the Favard classification is coronal plane deformity, and that describes patients who have rotator cuff tear arthropathy, which is a different pathologic process because of the superior humeral head migration and the superior glenoid wear. But typically there's a combination of both depending on the muscle quality of the rotator cuff, and actually the deformity can be three-dimensional, where you have a combination of both axial and coronal plane deformities. So the Favard classification was first described in JSCS in 2008, a radiographic study assessing the outcomes of reverse shoulder arthroplasty and scapular notching, but they also described the coronal wear pattern, and it's helpful for assessing reconstruction for when performing reverse shoulder arthroplasty. You have the E0, 1, 2, 3, and 4, and basically it's similar to the Walch classification, only in the coronal plane as opposed to the axial plane. E0 is superior humeral head migration without glenoid erosion. E1 is superior migration with concentric glenoid erosion. E2 is biconcavity. E3 is severe superior erosion with superior inclination that is significant, basically similar to the B3 in the axial plane. And then the E4 is inferior erosion. Identifying these coronal plane deformities is very important because you need to correct the joint line, correct the superior inclination, because otherwise the implants, especially in the reverse setting, will be placed in the abnormal position, can result in complications such as scapular notching, scapular pillar impingement, and implant failure, restricted range of motion, and poor outcomes. So here's some examples. Here's an A1, here's an A2, here's a B1, B2, and you can see this classic biconcavity on the CT scan. And here's an intraoperative photo where you can see anteriorly, you can see what looks like normal cartilage, and then posteriorly you can see erosion in a biconcave nature, and you can actually see the line of demarcation. And here's a B3. Similarly, now you can see the entirety of the glenoid is eroded, and you can no longer see that line of demarcation. Here's a classic C, where you can see the absence of the posterior glenoid neck. And then here's a C2, where you have hypoplasia, and now you have osteophyte formation as well as biconcavity. And here's a D, where you can see anterior humeral head subluxation and anterior erosion of the glenoid. Similarly, here's an E0, here's an E1, here's an E2, where you can see biconcavity in the coronal plane with superior humeral head migration. And then here's an E3 with severe superior inclination and severe superior glenoid bone loss. So now we move on to assessing the version, because we have to correct the version to help the survivorship of the implants and help with functional outcomes, period. The glenoid version typically, on average, ranges from 12 degrees of anteversion to 14 degrees of retroversion, but on average is about 2 degrees, and you want to correct to less than 10 degrees of retroversion to help with outcomes and survivorship of implants in the setting of anatomic total shoulder arthroplasty. So, as discussed, some studies have shown the risks of loosening of prosthetic glenoid implants with uncorrected glenoid version, mostly in the anatomic total shoulder arthroplasty setting. But studies have found that measurements taken with maintained retroversion and the arm taken through internal and external rotation edge loads the polyethylene component in an anatomic setting, which then leads to bone cement stresses, micromotion around the implants, implant loosening, bone loss, and implant failure. So a decentered or posterior displaced contact point increases the articular pressure and then creates significant stresses within the cement mantle and bone, up to 300% increases, and then micromotion of up to 700% increases, which results in loosening. So it found that glenoid retroversion exceeding 10 degrees should be corrected during anatomic total shoulder arthroplasty. Otherwise, you get these findings. And here's some characteristic diagrams from the study that was done using finite element, and they found that with retroversion that increased each 5 degrees, you can see how you move the arm through internal and external rotation, the head becomes decentered, and then you basically get the rocking horse phenomenon because of the net joint reactive forces being shifted as opposed to centered. And then that causes increase in all of the findings that we discussed and risk for failure. Similarly, a biomechanics study of glenoid retroversion and anatomic total shoulder arthroplasty found that components that were greater than 15 degrees resulted in excessive eccentric glenoid loading, decreased glenohumeral contact areas, increased contact pressure, wear, and loosening. So glenoid retroversion may result in eccentric loading of the glenoid component and led to wear, loosening, and the rocking horse phenomenon, which you can see what happens with edge loading. Similarly, with a cuff deficient shoulder, where you get coronal plane edge loading, if you have maintained retroversion greater than 10 to 15 degrees, then you get axial load micromotion and rocking horse phenomenon that will loosen the component and cause failure and bone loss. So how do we measure this? You assess on the axial plane. X-rays are technique dependent, not easily reproducible, and unless this is done with fluoroscopic control, it is not very accurate. And the best way to assess this is with CT scan, and this has been shown in 2003 in JSES, and found that the best way to assess this is with CT. The 2D CT cut just below the base of the coracoid allows for consistency, so everybody's looking at the same measurements when assessing this. And this is an example of where this is measured. So first and most commonly used way to assess this is with Friedman's line. Basically, it's a line in the scapular plane and uses the scapular axis. And then you draw a line, the glenoid plane, and then 90 degrees to that, and the angle formed between the 90 degree to the scapular axis and the glenoid line gives you your degrees of retroversion. The glenoid hole method, which is more recently described in JSES in 2017, uses the glenoid vault to assess the deformity, as seen by depicted in this line here. And it gives a better representation of actually what's occurring through the glenoid vault and may provide a better estimate of the actual and true intermediate glenoid version. Again, as terminology I used previously, the glenoid line is a line that connects the anterior and posterior edges of the glenoid, and this assesses the intermediate glenoid retroversion. It can be difficult to measure in the presence of glenoid wear or erosion, especially in the setting of a significant B2 or B3 glenoid, but oftentimes it will provide the intermediate glenoid version. Again, this is a description of the glenoid line with 3 reference lines of the neoglenoid, the paleoglenoid, and the intermediate glenoid. Here's assessment of the version of the paleoglenoid, the neoglenoid, and the intermediate glenoid. And again, this intermediate glenoid is a line drawn from anterior to posterior edges of the glenoid regardless of the erosion, and gives an assessment of what the true version is of the glenoid because it allows for the entirety of the vault to be assessed in the axial plane. And here's just an assessment of how to measure and validate these methods on CT scan using the intermediate glenoid line and Friedman's line with posterior glenoid erosion and posterior glenoid wear. And these allow us to assess exactly what needs to be done to reconstruct the glenoid, reassess and reconstruct the native glenoid to restore the joint line, and this improves functional outcomes, especially range of motion. Why is this important? Because if you do not assess these things, Walch found that if you do not correct the biconcavity in the anatomic setting, you get increased risk of failure, and instability. So he found in this study in 2012 that neoglenoid retroversion of greater than 27 degrees in a B2 glenoid, if uncorrected and an anatomic shoulder placed in these settings, you have 44% risk of complication at an average of 6-year follow-up, indicating that B2 and B3 glenoids should be of concern in the anatomic setting. And again, this is why some folks have used augmented polyethylene components in the anatomic shoulders and reverse prosthesis to get around this difficult problem. So now we go on to inclination. Inclination can be assessed in multiple ways, but the average inclination is a mean of inferior tilt of 2 degrees to superior tilt of 4 degrees. There's minimal evidence as to what the ideal amount of inclination should be and is different for both the anatomic and reverse setting. But significant superior inclination has been shown to be associated with increased risk of glenoid component failure. So how do we measure it? We measure it in the coronal plane. It can be assessed on an AP radiograph. Again, less accurate than CT, but the beta angle, which we'll describe in a minute, allows for assessment of the inclination of the glenoid when a good, true AP radiograph is obtained, although CT scan is much more accurate at this. And you can see an example of this. And here's how to assess the beta angle. And basically, it's a line through the supraspinatus fossa, and then a line connecting the superior and inferior aspect of the glenoid, and then provides an angle, and then you take 90 degrees from this, and that provides you with the beta angle. And this provides the entirety of the inclination of the glenoid, which is important in the setting of anatomic total shoulder arthroplasty to assure that you're correcting this and not placing the prosthesis in an inclined position that could risk failure. The critical shoulder angle is a line from superior to inferior aspect of the glenoid, as well as the most lateral aspect of the acromion, and provides also an assessment of the glenoid inclination and how it correlates with the acromion, which can give predictive information and distinguishes shoulders from primary osteoarthritis as opposed to rotator cuff arthropathy. Again, here's some studies looking at this and how it may correlate X-ray versus CT scan with minimal erosion. And when you have a significant increase in the critical shoulder angle, it may give an indication as to the status of the rotator cuff, and the pathology underlying may be associated with rotator cuff arthropathy as opposed to primary osteoarthritis. So basically, critical shoulder angle greater than 35 favors cuff tear arthropathy, less than 30 primary osteoarthritis. So this is important in the setting of anatomic shoulder arthroplasty and polyethylene glenoid component position. Now with the reverse prosthesis, we're placing this base plate at the inferior half of the glenoid. So this does not allow for a complete assessment of that inferior half and may under or overestimate the inclination. And so Boileau in 2017 described the reverse shoulder angle, which uses the supraspinatus fossa line and the inferior aspect of the glenoid, basically where the base plate would be placed, and gives an angle that assesses the inferior portion of this to allow for assessment of the inclination so this can be corrected. And this prevents insufficient correction of the superior inclination when considering only the beta angle, which is global representation of the base of the glenoid. And this is why he advocates for angled bio-RSA, because this allows for correction of the reverse shoulder angle, as you can see here, and you can see the angle of this bio-RSA that I was preparing for placement. And typically, this is on average about 20 degrees is within normal range, and you can see if you correct this to neutral, you'd be taking away a significant amount of inferior glenoid bone, and then you're medializing the joint line, which can restrict range of motion. So you have to relateralize the joint line, and this can be done with either bone or metal, or you can basically play it where it lies and correct this with bone and leave the bone where it is with this angled bio-RSA technique. Now, the other important aspect is the humeral alignment to the glenoid. So it is known, multiple studies found that posterior humeral subluxation results in glenoid component loosening, asymmetric polyethylene wear, and failure of anatomic total shoulder arthroplasties. And degree of subluxation is directly correlated with severity of posterior glenoid wear. And there have been several studies finding that anatomic total shoulder arthroplasties with posterior humeral head subluxation, preoperatively, the humeral head will go back to where it was postoperatively after time, and you'll have increasing pain, decreased external rotation, and worse patient-reported outcome scores. And even in 2003, in a study by Lannotti and Norris, found that the more severe posterior humeral head subluxation that was present, the worse the outcomes. And then similarly, Dr. Walch assessed his results of anatomic total shoulder arthroplasty in setting of B2 glenoids with significant posterior humeral head subluxation, and found a 16% revision rate at 6 years, 20% glenoid loosening rate, recurrence of posterior glenoid erosion, posterior humeral head subluxation, and 11% dislocation rate. And these were with neoglenoid retroversion of greater than 27 degrees, was correlated with a 44% complication rate. Intermediate glenoid retroversion of greater than 30 degrees, 62% complication rate. So it's important to correct both the posterior humeral subluxation as well as erosion and retroversion, as we've described. So the Walch index, which basically, as we alluded to earlier, allows you to assess using the glenoid line and the axis of the glenoid vault where the position of the humeral head is in relation to the center. And basically 50% is centered. So if you have something that is greater than 50% posterior humeral head subluxation, means it's posteriorly subluxed, and less than 45 degrees is anteriorly subluxed. And there's a mathematical equation for this ratio, but basically it allows you to determine whether the head is anterior or posterior in relation to the glenoid. And similarly, you can use the glenoid hole subluxation index in a similar fashion. It basically, one allows you to use the vault and scapular plane, the other one, the glenoid vault plane, to assess the position of the humeral head in relation to the center of the glenoid. So why is this helpful? It allows you to assess and differentiate more severe glenoid wear patterns, such as the A2 from the B3, as you can see here. Using the glenoid plane line as well as the glenoid hole plane line. And then you can see, is the humeral head truly centered, or is it monoconcave and recentered and giving that impression that it's recentered, but truly a B3 glenoid? Now, why does this matter? It may affect how you reconstruct the glenoid and reconstruct the joint line. And now that we have 3D reconstruction along with preoperative planning software, it gives us a 3D representation of these changes in multiple planes and not just in one cut of the CT scan. And found that for every increase in 1 degree of retroversion, there is a correlation of increased humeral head subluxation by 1%. So it's important to understand this, because the more severe retroversion correlates with more severe posterior humeral head subluxation, which makes sense. So golden rules for anatomic total shoulder arthroplasty: glenoid implant retroversion of less than 10 degrees, glenoid implant superior inclination of less than 10 degrees, glenoid implant backside seating of greater than 80%, less than 80% posterior humeral head subluxation, and subchondral bone preservation. If you cannot establish all of these things, then this would lead you to use a reverse prosthesis instead of an anatomic total shoulder arthroplasty, because all these findings, if you cannot follow these rules, lead to poor outcomes and implant failure. So you can see, here's an example of this. Glenoid implant retroversion less than 10 degrees. You want to make sure that you can correct that, and that's either with bone, metal, or augmented polyethylene components. Similarly, in the coronal plane, you want to avoid the edge loading that would occur with significant superior inclination. Backside seating greater than 80% to distribute the forces behind the polyethylene component and assure maintaining the prosthetic fixation and no debonding of the bone cement interface. As we discussed in detail, humeral head subluxation can correlate with edge loading and risk of failure, and preservation of the subchondral bone. Excessive reaming of the hard bone in the subchondral area will also lead to subsidence and failure of the prosthetic polyethylene component. So you need an armamentarium to select accurate glenoid positioning with glenoid implant selection. Preoperative planning software is very helpful. Now that we have advanced imaging, there's some patient-specific instrumentation, although this has not been shown to improve outcomes. The going through the process of planning does help with implant placement. There's navigation, and then future with mixed reality surgery. So you can see correcting the version. Classically, it was taught for eccentric reaming, and then subsequently went on to bone grafting. This has been shown to not do very well, and then augmented polyethylene components, and then the reverse prosthesis. Went on to preoperative planning software for guide wire placement. There's multiple companies that provide preoperative planning software to assess all of these characteristics we've been discussing. Patient-specific instrumentation. And then there's a company that now has navigation, where it gives real-time feedback of pin placement and glenoid placement. And now future, there's mixed reality, where there's real-time adjustments that can be made in the mixed reality setting. Thank you very much for your time.
Thank you, Mike, for the fantastic presentation. Very comprehensive lecture on pre-op planning. Just a few questions, Mike.
Yes.
What do you think is the role of 3D printing in shoulder pre-op?
So this is an emerging field. There's patient-specific implants that are going to be designed, and once FDA cleared in the United States, available mostly in the reverse prosthesis setting, where instead of having to sculpt the bone to fit the implants that are available, the preoperative planning CT scan will allow to a 3D printed augmented metal-backed base plate that fits the deformity. So theoretically, that saves time in the OR and saves bone. Obviously, this is future instrumentation, but this is on the horizon.
Thanks,
I don't
Mike.
think you can do. Yeah, I don't think you can do this with the polyethylene anatomic shoulders because you can't change the configuration of the polyethylene, but if you're dealing with that severe deformity, you're probably leaning toward a reverse prosthesis anyway.
Thank you, Mike, for that. And Mike, you've mentioned scenarios where the anatomic shoulder wouldn't work, right? There are those 5 examples that you've mentioned. Now, so in that case, a reverse shoulder should be a more forgiving implant, isn't it? So are there any situations where a reverse shoulder wouldn't work?
So this is very debatable in terms of, some people are very dogmatic about when to use anatomic, when to use reverse prosthesis, and some follow the guidelines that were outlined. The contraindications to reverse prosthesis are axillary nerve dysfunction and infection. Those two are pretty much the mainstay of when not to use it, but otherwise it's at the surgeon's judgment and how they feel based on the evidence and the literature available and how they think it's appropriate with regards to functional outcome and survivorship.
And so, Mike, suppose someone has done a proximal humerus fixation using a lateral approach, and you're not sure whether the axillary nerve is intact or preserved. How do you really judge whether the axillary nerve was injured in case he required a reverse shoulder because of failure?
Yeah, if you can't tell on clinical examination, EMG and nerve conduction study are your best modality. That'll give you assessment of is the deltoid functional and is the nerve in continuity.
So do you get that for all your patients where you suspect an axillary nerve palsy?
Anybody who's got any type of axillary nerve dysfunction, I do. So if they even have sensory changes and it's in a revision setting, or you say it's a fracture dislocation, I will obtain one.
Thank Michael. And Senthil is also online. Senthil is a staff orthopedic surgeon based in Texas, UT Southwestern. Senthil, your questions to Mike.
Hi, Mike. Thanks.
Hey.
Thanks for your time. It's a really good presentation. So I think we should follow up with more talks on your. I know you do a lot of reverse shoulder arthroplasties, and you're more of a reverse guy than an anatomic, is my opinion about you. And your patients do really well. So, do you have any age cutoff on a reverse shoulder?
I don't. I think it's depending on the patient, the host factors that I described. So, if I have a somebody who's 40 and failed multiple cuff repairs and has a massive irreparable rotator cuff tear and findings of cuff tear arthropathy, I will not hesitate to put a reverse prosthesis in a patient like that. If they have something that is still correctable, meaning that they have soft tissue that is still present, the subscapularis may still be present, there's no arthritis, there's not a significant amount of proximal humeral hand migration, then that may be a patient who is a good indication for lower trapezius transfer. On the horizon, once it's FDA cleared, there's also the balloon arthroplasty in the subacromial space that may give these patients a little bit more time. But I don't really have an age cutoff. Several of the folks who have done this a lot longer than I have good outcomes, survivorship at 15 to 20 years that show greater than 90% survivorship in the setting of primary OA or cuff tear arthropathy.
And after you do a reverse, do you put any restrictions on the patients? Do you kind of profile them with their work and stuff?
Yeah, so my restrictions for the first 3 months is nothing, no extension, so nothing behind the back. And then after that, I let them do full range of motion. And I don't really give them a weight restriction. I tell them if there's somebody who's very active and likes to do a lot of exercise, I tell them no pull-ups and no weight-bearing activities behind the back. But it's very difficult for a patient to reach the weight cutoff because it's about 20 to 25 pounds in one hand with the arm outstretched in the scapular plane, which is something that most people are not doing in their daily activities. So most people who've undergone this operation don't really have a lot of restrictions. Now, if it's a construction worker who's doing a lot of punishing activities to the shoulder, I might tell them to find a different vocation, because we don't want them really punishing the shoulder, because we don't know the consequences of that, especially with the newer technology and the bone ingrowth or the bio-RSA techniques. We don't know, are these at risk for loosening and failure, such as an anatomic shoulder would be with repeated load like that. I've not seen these patients come back yet, and I've got 10-year follow-up on some of them, but we don't know what the occurrence of this is. Now in Texas, the biggest question I get is when can somebody go back to shooting? Now I have no data to support when or if they can do that. It's a very difficult study to do because we don't want somebody fatiguing a shoulder to failure, but it's a very common question. But that's, I think, because of the geographic location that I practice in.
Okay, and you mentioned about patient-specific instrumentation. how often you use it in your practice? Do you use it routinely, or you kind of use it on any specific
I
indication?
plan every case. The only times I will order a patient-specific guide is mostly for when I have residents with me at Parkland, our county hospital, because it shows them a bit better where to place the guide pin more accurately, because that's for them in their training a lot more hands-on location as opposed to on the university side where it's more hands-off for the residents. And so I because of cost restraints, I don't order a guide for everybody.
Okay, all right. I think yeah, it's a good question. I think we should follow it up with a technique talk. I know you kind of do your reverse in a very sleek manner, and you have a very good techniques for exposing the glenoid, which is the toughest part. I think we should do one.
Oh, absolutely. Yeah, we can. I'm happy to do a video technique talk. That's easy.
Okay, sounds great. Hitesh, I don't have any more questions. Do you have any?
That's it, Sendil. Thank you, Mike, for that fantastic presentation. Very, very comprehensive. And if someone wants to do shoulder arthroplasty, this is going to be a very, very useful and informative talk. And thank you so much, Michael, for your valuable time and spending with us. And surely this is going to be a lecture that's going to be useful for thousands of people all over the world. Thank you so much, Michael.
Thank you for inviting me.